Is everything working? Okay, good. I got a lot of thumbs up. Thank you. Thank you, everybody. So hi, I'm Allison Cowan. I'm the Deputy Training Director at the Wright State Psychiatry Residency Training Program, and I'm a psychiatrist for Ohio's Telepsychiatry Project for Intellectual Disability. So we've been doing telepsychiatry across the state of Ohio since our pilot project in 2012. I just have to brag about it. Sorry. And I want to let you know that I don't have any conflicts of interest, and I don't receive any pharmaceutical funding. That's just one of those disclosures that I do at the beginning of presentations. And then I wanted to talk about why I selected this topic. I was just thinking that as many times as I make the same few categories of diagnoses, so like psychotic disorders or depression or anxiety, bipolar disorders or trauma, every diagnosis is different because each person that I talk to is different. And it's just so helpful to remember the different ways that we're all different. I'll just say different a lot of different times today. Oh, there, we can, maybe that's the thing we can keep track of, like how many times I say it. Okay, and let me see if I can click. Yes, okay, so our objectives. So first, we are going to, at the end of this presentation, you will be able to define culture. You will be able to describe methods of culturally competent care. And you will be able to use case examples to practice these methods that we will talk about today. So that is my announcer voice. All right, so let's talk about the definition of culture. So culture includes language, religion, spirituality, family structure, life stages, ceremonies, rituals, customs, and morals and legal systems of a group of people. So let's look at each one of those. So language. Oh, I'm gonna list a long list of questions. I don't expect you to answer. These are rhetorical questions. Plus we're in a Zoom meeting, so actually answering questions is a little bit difficult, but just kind of think about each way, each one of these variables can be different. That will describe the different ways that you can have and experience culture. So language, what language is spoken in the home? Is it the same as at work? Do two sides of the same family speak different languages? What are the language expectations? And then religion, what is the person's religion? Has that changed? Did they grow up in one religion and they've left it to go to another? How important is religion in their life? And then spirituality, a person can be spiritual, they can describe themselves as spiritual but not religious. That's a different, an important distinction to make for some people. And then family structure. So is a child or adult child expected to live at home for as long as they need or want? Or are they expected to live there until they're married? Are they expected to leave home just as soon as they can support themselves? How many generations live together? How many generations are expected to live and support each other together? And then life stages. So what are the cultural expectations? So if you're in your 20s, are you supposed to be working on your family, or are you supposed to be working on your advanced degree? Like depending on what your culture says you should be doing. And then ceremonies. What ceremonies and rituals are important? So this would be like, it could be religious ceremonies, it could be like Sweet 16 parties, like what things are important in recognizing a person's like stage in life or like important events to celebrate. And then what are the moral guidelines that compel the person that we're talking about? And then how are the legal systems treated in that culture? So just a language note, I will be using the term patient. I am a doctor, so I see patients, but please feel free in your mind to substitute client, individual, person, like whatever other term. I try to use individual, patient, or person. So that's just a note. Oh no, it went backwards. Oh no, it didn't. Okay, sorry, this is my next question. It's the title slide, so I got confused. Okay, so this is, I asked her first, so it's not stealing, I guess, from my friend and colleague, Dr. Jessica Porcelain. So this is a question that sometimes can make you squirm. It can make you feel kind of squirmy inside. So do you personally feel culturally competent? Like if I ask you, are you culturally competent? what would your answer be? Again, this is rhetorical. You can shout out if you're on mute, that's fine. So you might get a feeling like, oh no, I don't know every single different permutation of every person on this earth that I feel like I should know. So I don't know every individual thing. So hopefully, if that's your answer, hopefully I'll be able to let you feel more confident after today. That's my goal. That's, I guess, one of my objectives, like my secret objectives. All right, so before we talk about the methods of like cultural competence, let's talk about this idea or this framework of cultural humility. So Tervalon et al. Talked about this in 1998. That's kind of when I first found it discussed. And so here we have like our little circle for the visual learners here. So cultural humility is this idea that like in a medical or a psychiatric situation, that there is going to be a power imbalance, and it's going to happen in the setting of diversity. And that if we approach people with cultural humility, meaning an openness, self-awareness, egolessness, and a supportive interaction, self-reflection, and with self-reflection and critique, that hopefully that leads to lifelong learning, and that it lets us get all of these great things listed down here: empowerment, partnerships, benefit, optimal care, and respect. So that's kind of the approach. So that if we approach things not knowing and asking people, that we can be better learners. All right, so the DSM-5 talks about the Cultural Formulation Interview. So in 2013, the new DSM came out, and it talks about obtaining the patient's understanding of their problem, asking about the role of cultural identity or background. We're supposed to ask about cultural factors affecting current help seeking and assess the clinician-patient relationship. Before that, there was a list of culture-bound syndromes. That list is still in there, but it's more of a glossary of terms to kind of help you. Like if somebody says, I have this culture-bound syndrome, or like if they use the name, you could kind of go look it up in there. But the DSM-5 really moves to this model of asking the patient how they experience cultural factors. And I think it's a really thoughtful, thorough interview, and it's like several pages long. And if anybody asked me all those questions, I would feel very seen. It's a very like sweet, good, structured interview. Now, if you look at a list of, like 3 or 4 pages of questions you're supposed to ask, it might feel overwhelming. How are you supposed to fold that into your usual clinical work? Oh, here's like an example of what it looks like. So there's interviewer guide, there's the questions you're supposed to ask on the sides. But if that seems kind of overwhelming for you, we have the 4 C's. Look at this, so easy to remember: call, cause, cope, and concerns. It's very helpful. Now, if you don't know what those mean, I've included this little helpful thing. So the call is, what do you call your problem? What's the name of this? And then what do you think caused your problem? How do you cope with your condition? And then what are the concerns about the treatment? So those help us kind of frame the questions. There are some little examples in there that if you can read them, you might have to squint. But just like questions to ask what it means. Okay, so then we'll use the 4 C's as we talk about our case 1. So what do they say on TV shows? Any resemblance to any fictional or non-fictional characters is purely coincidental. So these are fictional. So don't worry. If you're sitting there worried, I'm about to tell patient secrets, I'm not. So, all right, so let me find my little thing. Okay, are you ready? So Ms. A was brought to the clinic because her team is worried she's depressed. So Ms. A has mild intellectual disability. She comes to the clinic with her older sister and her new provider agency program manager. The program manager is worried because Ms. A only takes a shower once a week and wears dirty clothes. So I think we all might say, oh gosh, well that sounds like depression. So if we use our 4 C's, the first one is call. What does the patient call this? So when we ask, Miss A, what do you call this? The patient says, well, it's normal. That's just how I do things. And then if we ask the sister, what do you call this? And the sister says, well, it's normal. And then if we ask the program manager says, yes, well, I mean, I guess if she gets dirty, she'll take a shower. And if the clothes get food on them, she'll change her clothes. And yeah, she does get washed up every day. Like I don't know what, some people call it a bird bath or a spit bath, like with a washcloth, like washing up. So that's kind of what's being described. So then our second C is cause. So if we ask the patient, what do you think caused this? The sister might step in and she'd say, well, we grew up in a family property that didn't have any running water. Like we would have to go out to the well and hand pump any water that we used. So I think that's a good cultural factor to know. In doing this, I also looked up, did you know that 2 million people in America don't have access to running water like in their homes? So just FYI, this is the thing that happens more often. So if a person grows up like that, it might be very typical to only take a shower once a week, especially if you're pumping and hauling the water yourself. So then how would you cope with this? So this might be more of an educational system, like both for the program manager and for the family. How can we make things easier here? Okay, and then concerns is the last one. So let's go on to case number 2. Okay, so Mr. B has intellectual disability as well. His team says he's not getting out of bed, he's not showering, he endorses depressed mood, low energy, poor appetite, difficulty concentrating, guilt about things that he's done in the past. So if we use our 4 C's, the first is call. So like if we ask him, what do you call this? And he would say, well, I guess depression, but I heard my pastor call it being spiritually sick once. Okay, well, that's interesting to know. So number 2 is cause. So if we ask him, what do you think caused this? And if he says, well, I worry I don't pray enough and that I've been sinful and this is punishment, that's a good cultural factor to know. And number 3 is cope. The third C is cope. So how do you cope with this? And the patient says, well, I try to pray more, but I don't know if it's helping. And number 4, concerns, like what concerns do you have about this spiritual sickness, as you call it? And so the patient says, well, what if this means that I can't go to heaven to see my mom and dad who have died? So what happens when I die? Will I be able to see them? So this can let us know how cultural factors are very important because maybe just prescribing escitalopram or sertraline to this person is not going to address his actual concerns, and a cultural formulation would help us understand that. So hopefully that was helpful walking through those. I have a list of do's of providing care. So try to understand people's values since that will influence their behavior. Keep in mind that there's always individual variation within a group. Learn about the beliefs and practices of the patient populations you serve. Develop a tolerant, accepting attitude about views that are different from your own. That last one is like a common sense one, but it's something that is always useful to help reminding ourselves because it's so easy to slip back into our kind of normal operating procedure. And I found this helpful, Georgetown University's Health Policy Institute. Obviously, there are more than the ones listed here. I picked the ones I liked best. So provide interpreter services, recruit and retain minority staff, provide training to increase cultural awareness, include family and community members in healthcare decisions. I must coordinate with traditional healers, and then provide linguistic competency across all avenues. And then the key takeaways. So please strive for cultural humility, not competence. So that kind of lifelong learning, always asking the patient or individual you're working with. And then acknowledge that culture can influence diagnosis and treatment. And then use the 4 C's or the cultural formulation interview. I think that's it.
Mic drop.